I may have mentioned this already, but I try to keep these videos to 10 to 15 minutes each. Gives you a chance to stretch, gives me a chance to stretch. Anyway, pathophysiology continued. Reduced blood flow, toxins, tubular ischemia. Think about what is tubular ischemia. Infections and obstructions, these all have different effects on the renal system. Any of these can decrease your glomerular filtration rate. They can disrupt the tubular membrane, and they can obstruct urine flow in these tubules by producing renal blood vessel constriction, by producing inflammation, and or by obstructing the formation or the outflow of urine. So when the pressure in the renal tubulars is greater than the glomerular hydrostatic pressure, then glomerular filtration stops. So let's stop and think about that. Where does glomerular hydrostatic pressure come from? Stop and think about that for a minute. What produces the glomerular hydrostatic pressure? What is hydrostatic pressure? Anyway, when the pressure in the renal tubules is greater than this glomerular hydrostatic pressure, then glomerular filtration stops. And when you're not filtering, then these nitrogenous waste products start to build up in the blood. And we see that as elevations in blood urea nitrogen and in creatinine. Okay, now let's back up here a minute. Did you remember what hydrostatic pressure was from fluid and electrolytes? I was there when your fluid and electrolyte content was covered, and I know this stuff was mentioned. Hydrostatic is the pushing pressure, pushes fluid, and the glomerular hydrostatic pressure is generated by your blood pressure or by the pressure of the fluid in your blood vessels, which that's also probably a decent definition or part of what generates your blood pressure. If we consider causes of acute renal failure, and by the way, this picture is on the blackboard if you need to look at it again. You also have it, in a smaller version. I don't necessarily think you need to print this. Causes of acute renal failure. Pre-renal. Now notice here, this picture uses the older terminology. So pre-renal, a sudden and severe drop in blood pressure or an interruption of blood flow to the kidneys from a severe illness or injury. So number 1 represents blood flowing to the kidneys. And anything that interrupts that blood flow to the kidneys, like septic shock, where your overall blood pressure has significantly lowered, trauma, where the patient is bleeding out somewhere, heart failure, where the heart just won't pump it down here, those can produce pre-renal situations. Now, if we correct these pre-renal situations in a reasonably prompt manner, we may prevent the reduced blood flow from becoming so severe that the kidney itself actually becomes adversely affected. Pre-renal causes, I've mentioned some of these already. A decrease in vascular volume, like the patient's hemorrhaging. What if the patient isn't getting enough intake and they become dehydrated? Now, I know you've already covered nephrotic syndrome, and in nephrotic syndrome, what happens is so much protein is lost in the urine that there is more protein in the patient's tissues, so fluid moves from the vascular space into the interstitial spaces, and that movement keeps the vascular space or causes the vascular space to be dry and produces a vascular dehydration in the presence of tissue edema. So you've got a very puffy person and you have a dehydrated vascular space. Decrease in cardiac output. If the heart can't pump it to the kidneys are going to have poor perfusion. Someone who has an acute myocardial infarction, also known as a heart attack, someone who has heart failure, someone who has post-op hypotension. Sometimes the medications, the anesthesia, the pain medications can produce decrease pumping action of the heart, or can cause vasodilation of the blood vessels. Intravascular pooling. So here you've got blood in the vascular space, but it's pooled. Septic shock causes a vasodilation and allows for pooling, as does anaphylactic shock. Neurologic injury that damages spinal cord at certain levels causes the nerves not to properly innervate the blood vessels. A obstruction in the actual blood vessels supplying the kidneys, like a renal artery stenosis. Just picture it. The renal artery has a narrowing in it. Or there's a clot that doesn't allow for the blood to properly flow. An embolus that has traveled and obstructed a renal blood vessel. And some vascular surgeries. If I have to do surgery on a patient's aorta, by the way, I don't do surgery on patients' aortas, but if there's surgery on a patient's aorta and they have to clamp the aorta, then the kidneys may not be perfused during that time. If we consider these pre-renal causes, or I like to think of them as pre-renal oliguria with the potential to cause acute kidney failure. And I say the potential to cause because if we correct pre-renal, then the kidney doesn't have to become damaged and it just reverses itself nicely. So if we're looking at the blood and the urine in pre-renal, and notice I've got bold-faced oliguria. So, you know, is this acute kidney injury? Yes, by the new criteria, but it is readily reversible if we catch it early. So in this situation where we see these symptoms and we intervene, we may prevent that patient from having to go on dialysis. And that's a good way to think about it. You know, the patient can have acute kidney injury resulting in dialysis, or the patient can have acute kidney injury that very quickly resolves and normal function returns. So, in a pre-renal oliguria, this is a situation where the kidney proper has the capacity to do what it needs to do if we would just improve the conditions. So think about what is supposed